All right, it's 9:30. It's April 22nd. And I'm calling the Prescription Drug Affordability Board officially to order. To establish a quorum. Let's go around the room first and introduce who we are. My name is Gary Merchant. I'm state representative representing Sullivan County, District 6, which is Claremont and Croydon, and also the chair of the board itself.
Senator Cindy Rosenwald, I represent Nashua, District 13.
Bob Woodward, alternate, or emeritus professor at UNH.
Jason Azes, Director of Health Economics at the New Hampshire Insurance Department.
Kirk Williamson, I'm the executive director of the BDAP.
And thank you for today to establish a quorum. I will take the honor of elevating Dr. Woodward as a full member, and also Dr. Hazard from also a full member. So you'll be representing, if you will, people from the House, which is appointed by the Speaker, and you would represent the people from the Governor's office. With that, we have now a quorum. There's a question about the minutes. We'd like to break the minutes into two. So I will have the motion begin on the floor on the February meeting minutes, which is February 26th.
So move.
Second.
Second. All those in favor say aye.
Abstain.
Abstain. We don't, is there anyone on the Zoom?
No, not from.
Good. Because if there is, we have to do a roll call. All right, on to the March minutes. Have a motion on the March minutes.
Yes, moved.
Second.
Any discussion? Hearing none. Vote on the minutes for March 25th. All those in favor say aye.
Aye.
All those opposed? Abstain? The ayes have it. Moving on to the rest of the agenda, legislative updates. Right now, the House Bill 1365, which is going over to the Senate, that's dealing with biologics, and that's trying to, at that point in time, use the market itself to let people compete in the market to do what the market's supposed to do, is to bring costs down. So the bill, the intent of it is to allow a pharmacist at that point to substitute between interchangeable biologics. So basically, A, according to the FDA, if A is interchangeable with B and A is interchangeable with C, the bill says that the pharmacist can interchange B with C, which is the same thing we do on the generic side. Just people don't understand, but education-wise, when you are a generic manufacturer on the generic side, you have to show equivalency with the brand. You don't have to show equivalency with every other generic on the market. Yet we can substitute between generic products because they've been shown to be identical, if you will, with the branding. So pharmacists have the ability to substitute between A, B, C, and D. There it is.
Sorry for being late. Takes
We'll
longer
take
to
it out
get
of
here
your,
than I
we'll
thought.
take it out of your paycheck, don't worry about it.
Yeah.
Okay. In regards to the other legislative updates, I don't think there's anything else going on in the House or the Senate that I know of that impacts this board. I do think once we get through the issue of the redundancy report for the next legislative cycle, is thinking about what we want to do as far as introducing legislation that may help clarify things based upon what we talked about today with the mission and so forth. But right now, it's the only thing I know of that's going on.
Is it worth updating the fiscal committee decision? Did you already do that?
Not yet, not officially, but you want to jump onto it quick.
So, so this week we had, an item, supplied by our executive director, to the joint fiscal committee. It was a reasonable request of, reprogramming a few dollars so that there was some money available to reimburse in-state travel and some out-of-state travel. All very reasonable, non-controversial stuff. These are new accounts. We need to establish some new accounts to support the operations. The issues that came up in the fiscal committee were really about protocol and process. It happened that on the funding request, the transfer of funds, it was signed by the executive director, and the travel reimbursement was, going to benefit the executive director, traveling on our behalf, but there appeared to be a conflict of interest in the paperwork that wasn't there in the real world, not there in the real world. But from process perspective, we may want to implement a procedure to where, particularly when something goes to the joint fiscal committee, it benefits the signatory of the request, that get board approval, just to make sure that there is no concern about an appearance of a conflict of interest. And it was merely an appearance. There was no real conflict. So I think that's the biggest thing that came out of it. What was your opinion?
I would concur. I think one of the things that we need to think about is going down to the rulemaking is what is the process for the financial side of what you're talking about, is that we have budget. How do we work with Mr. Williamson, certain things that if he wants to do whatever's going on, what's the process that he goes through to get an approval if we need to do that? But we're now in rules, we don't have that element. I think what you raised has some value to it. And we need to think about how to revise the rules or include. It's not revising it, we don't have anything in the rulemaking that I know of dealing with this kind of an issue. Didn't think about it, quite frankly. So I think going forward, Mr. Williamson and Mr. Berry can talk about rulemaking about how to address this.
I don't know that, do we, Mr. Chair, do we need to wait for rules though to implement some common sense stuff that we think we ought to do? I mean, we probably don't have another joint fiscal committee request, in the foreseeable future, but couldn't we just say that sort of thing needs board approval without going through rules?
I would like to have something in the rules, basically, not just for this one situation, but to cover things in general. You know, what's the process if he wants to do something, who signs off on it, for instance? Is it something that we do, we bring everything to the board, or we basically have a process in place, the board is approved, and therefore, based upon that board approval, what the process the board approves, what we can utilize, versus everything coming to the board.
One of the issues might be timing. Things might need to get done before board approval could be achieved or implemented.
Mhm.
What you're thinking about things that need to get done tomorrow and the board meeting's a month away.
Sorry.
Well, I mean, if we're gonna make a transfer, it has to go through fiscal. Anyway, and that is once a month, so things can't get approved on a dime.
There's things I'm trying to think through here, is going to fiscal, if we want to move money around between the lines. But if all of a sudden we want to allocate something, let's say he wants to take an educational conference to attend it, who's gonna sign off on it? It's just those little things like that I think we need to
Well,
be clear on.
what happens elsewhere in the department when the legislature or the fiscal committee approves money for educational expenses?
I
think you'd have to go through your supervisor for that.
Is that something it's in a policy somewhere or something? That's the rules, because if it's a policy, then the board can approve the policy.
Policy more than approval.
But Kurt is the supervisor.
Technically, the department, my supervisor is Nathan White,
Oh,
the
okay.
CFO.
Yep.
So I talked with Nathan White about this, and I also did this in collaboration with Gary, with the board chair. So
Nathan is your supervisor?
technically,
It's a,
it's an operational thing.
yeah, it's a paper supervisor, because
Yeah.
that's the way we have to work.
Interesting.
So that's,
Yeah. He's not just any supervisor.
it's a takeaway, if you don't mind asking Mr. White, Nathan White, you know, what we can use as a policy, because if the department has a policy, then we can make that policy back to the board. The board can then vote on that policy and it becomes more of a policy versus rules.
Yeah, so to the point about supervision, I I don't want to assume it, but I have assumed that everyone just believes that the board supervises the executive director. Right?
Yes and no. As far as his work and things of that nature comes under the board. I think from a process point of view, in order to have him receive a paycheck, someone has to sign off on it.
Yeah, so the way it has to be set up in, the personnel is, an employee has to be supervised by another employee. Since you individuals are not employees, we have to have Nathan White as the paper supervisor, but he's only there, as a dotted line, so to speak. He doesn't have any control over the work or any of that, stuff.
But that's where the board comes in.
Correct, yeah, that's the board.
That's the board.
So he's purely administrative.
So is that all I'm clear, or does that have to be put into rules too? I'm just asking, it's maybe a rhetorical question.
I don't think so.
I don't think so.
No, because we have a personnel policy, right?
Yeah.
Yep. So as far as that's the fiscal update, which is D on the May meeting, we have a meeting on May 13th. Again, it's for strictly talking about data. What data does the board need to do its work? Where do we park the data, where we find the data, and then who has access to it? So that's kind of the intent on the May 13th meeting, is really drill down into what are we gonna do with data, because in the redundancy report, there's some issues about the data overlap. So we need to think about, what goes here, what goes there, so that ultimately, when we get ready to work on, pick a project, whatever's happening is, how do we get the data we need in order to make strategic decisions going forward? External communications, I think it's yours.
Yeah, so we now have access to a platform called Gov Delivery, which is what the department uses to send out meeting notices, press releases and the like. So now we have the ability to do that. So hopefully we can reach a broader audience. We now have somewhere around 160 subscribers, which is pretty good, for just having this for a month. I also want to discuss the Stakeholder Advisory Council. I know that was a goal of the board this year. I let you all know that we have 11 out of the 12 individuals now on the Stakeholder Advisory Council. We can issue a press release to let everybody know who's serving. And I can also give you all a verbal reading of who all is on the board or on the council right now. That consists of Cassie Keene in the Department of Administrative Services, Benjamin Carbone in the Department of Corrections, David Chorney, the Deputy Medicaid Director in the Department of Health, Duncan Edgar, an attorney at the New Hampshire Department of Justice, Joyce Pittman, a Director of Risk and Benefits at the Department of Administrative Services, Rich Gullah, the President of the New Hampshire State Employees Association, Megan Tuttle, President of the New Hampshire Education Association, Jean Herrick, General Counsel at Health Trust, James McGrail, the Chief Human Resources Officer at the University System of New Hampshire, Sarah Sawyer, the Chief Human Resources Officer at the Community College System of New Hampshire, and Tyler Brannon, the Senior Health Economist at Barry Dunn, who was nominated as the Consumer Advocate. So we have quite an experienced council that I'm hopeful will be a good resource for all of you as you make more tougher policy decisions and get down the role of implementing this legislation. So we'll probably discuss at the next meeting how we want those first initial meetings to run, how we should introduce you all, what should be the topics of discussion, particularly since they are advisory. What are you looking for advice on? If it is a specific policy or if it's some more general questions, but we can discuss that more at the next meeting when we have some dedicated time. But I can
That's the
pause there.
June meeting.
June meeting. Yeah, not the May data meeting, but the June. Meeting. Thank you for clarifying.
Well, thank you for that, and also thank you, congratulations on finding 11, 12.
Yeah. Great.
Not
A lot of emailing, yeah.
A lot of good work.
Who's the missing 12th? What positional?
Yeah, it's the
Position.
governor.
The
or
governor
his
appointing?
designee. Yeah,
Okay.
yeah. He's got a lot of stuff going.
there anything else that you want to bring up? As far as-
I don't think as it pertains to this important.
So on the agenda today, we wanted to talk about defining, sort of drilling down, what is the collectively our understanding of our mission? And this back to affordability to whom? Tried at that point in time, because we don't have a clear understanding of what our mission is, it's difficult to go forward. So this discussion today, I've asked Mr. Williamson to put together a slide deck, quick one, to kind of ground us in that direction. If you want to take it away. Williamson.
And I lost my voice yesterday, so I apologize if I don't sound excited. I am very excited to present on affordability. So several years ago, Granite Stater spoke up in recognition that this system was not working for them. And that we as a state must do something to ensure that people aren't sick because they're poor or because they're sick. And we know that when you postpone dealing with problems, that they get bigger and that they cost more over time. Which is why it's so important to have this type of discussion today, where you're engaging as a public body around a shared priority like prescription drugs. By setting the right priorities now, I think you all will be best positioned to leverage resources over time so that we can accomplish what we set out to achieve today. Go to the next slide, please. So I think the basic reality that PDABs must address head on is that resources for prescription drugs are not unlimited. That is the inescapable goal that you all must contend with, that whether New Hampshire can pay for prescription drugs for people who need it, given budget constraints. And I think the mission of the PDAB, while it may seem, audacious in the abstract, it doesn't mean that it's not a worthwhile pursuit. As such, I think it's important to think how long it may take to achieve its mission, and what resources we may need to do this effectively. And so I think Gary mentioned it, that the goal today really is for you all to come to some sort of general consensus on what you see as the mission of the board. What does it mean to bring about affordability of prescription drugs and to whom? So we can go to the next slide. So as I mentioned on the last slide, the PDABs generally here or in another state must wrestle with the tension between two inescapable goals. First, that insurance allows patients and clinicians to use healthcare services as they best see fit. And second, that there's a need to manage resources fairly within budget constraints. And while this tension may exist all throughout the healthcare system, it may not be anywhere more fiercely debated than when it comes to prescription drugs. The cost of prescription drugs has become one of the largest components of healthcare spending, and it's projected to continue to increase relative to all other spending areas in healthcare. In fact, the average cost of a new medicine to consumers in 2023 was $300,000 a year. That was up from $220,000 in 2022. Who can afford that, right? And if a prescription drug causes rapid growth in the short term, payers are pressured, whether that's public or private, to make short-term decisions on how to find the needed resources. In other words, money. This may lead to decisions to increase deductibles or otherwise reduce healthcare benefits for employers. And as an example, would be the state government, such as ours, might need to reduce a housing budget or an education budget just to keep Medicaid afloat. And for providers, that might mean you have to forego hiring needed staff. It could also mean you have to delay the introduction of other high-value healthcare services. And so to manage this tension, this challenge, PDABs must weigh the budget impact of prescription drug spending, the cost to consumers, and the coverage and access criteria in place by insurance plans that operate in the state to determine what is affordable and what is not. So you're ultimately answering the question, does this drug or a set of drugs create excess cost to patients, the system, and or both? Let me get the next slide. So what does affordable mean? And I think when you're looking at prescription drugs and you're looking at spending, when you're putting on the different glasses of the patient, of the state, it's going to shape how you view affordability. There are different aspects of affordability, and I think it might save you all some time. Then rather than thinking about all the different market prices and the reimbursement rates, And instead, just thoroughly consider cost and spending. What are the net costs and what is the net spending? Patient access must be said. It's a function of cost and or spending. Patients pay cost sharing to access the product. Employer and commercial plans spend money on a product. Governments spend money on prescription drugs. Manufacturers give rebates to get onto the market. So of course, you can't ignore the market prices and reimbursement rates that are essential to this work. But on the whole, I think affordability really revolves around costs in the market rather than all the various insurer and public program reimbursement rates. You can also think about affordability as excessive costs, and to whom do they accrue to? Do they accrue to patients such that their out-of-pocket costs make them forego the medication at the pharmacy counter? And we know that if people do not take the medicines as prescribed, it leads to poor health outcomes. Do the excess costs accrue to consumers? Are our premiums increasing? Are our deductibles increasing? Are employers having to forego wage increases? And do these excess costs justify the health gains given other therapeutic alternatives that are already on the market? And just so that you all have some data to ground it in what we're dealing with in New Hampshire, I looked at the 2023 New Hampshire Insurance Department Annual Hearing Report, which is chock full of information. And just in 2022, pharmacy per member per month allowed claims increased 8.8% from 2020 to 2021, and then again 5.7% from 2021 to 2022. Specialty drugs contributed to 56% of total pharmacy spending in 2022, and that's up from 47% in 2019. And then when you look at the individual market, all service categories decreased except for pharmacy. Pharmacy was the only one to increase in 2022. So then if we zoom out a little bit and see how that compares to other economic realities, the inflation rate in 2021 was 4.7%. And in 2020, it was 1.23%. And that is well below what the per member per month increases were on the allowed pharmacy claims. And over that same time period, real median household income in New Hampshire decreased 15% from $100,000 in 2020 to $84,000 in 2022. So prescription drug spending is rising, people are paying more out of pocket and they're taking home less. So you can go to the next slide. So it's important to remember that the healthcare system consists of multiple players, both payers and purchasers, which makes the concept of willingness to pay less of a rigid definition and much more of a fluid perspective. And it's for a variety of reasons. Patients with commercial insurance, they're exposed to different copays. They experience different cost sharing based on their plan benefit design. So their willingness to pay is completely dependent on the drug price and the insurance plan in which they're in. Plan sponsors, they carefully evaluate their willingness to pay based on the merits and costs of a product, as well as the need to finance all other aspects of their operation, whether that's pharmaceuticals or medical services. PBMs, they don't have to balance competing cost pressures because PBMs are not at financial risk, which is very unlike their health plan clients. And people without insurance, they may face the greatest affordability challenges. And as you all know, Medicaid, they must cover all FDA-approved drugs. So Medicaid, they don't have the luxury of excluding a drug from a formulary. They must provide access to that drug. Now, they do get rebates or the best price, but they can't exclude a drug. In 2022, Medicaid covered 134,000 New Hampshire residents. That's roughly 10% of our population. And I went back and looked at Dr. Woodward's presentation on Medicaid drug expenditures, and he found that Medicaid pharmacy spending increased 35.9% from 2018 to 2022. That's $80 million for 10% of the population. And another factor that can affect a patient's affordability or even access is whether an independent community pharmacy can procure that drug. Can they stock that drug? Or is it too expensive? And that's in contrast to retail big box chains pharmacies. Can independent pharmacies stock these biologic drugs? Can they afford to do that? And are they under reimbursed for that product, as we've heard from PBMs in their contracts? Or are we going to do something to allow independent pharmacies to maybe procure at a lower price, or so that they are not held at such financial risk? And if an independent pharmacy must lose money to dispense a high-cost product and they likely cannot stock it, that will have cascading negative effects, which harms patients and sometimes entire communities. And then there's also the manufacturers, I'll say, willingness to discount. Manufacturers may provide hefty rebates, but that's because the drug is so expensive. Patients may not be able to shoulder a high cost sharing burden. And when you're thinking about affordability, again, you may also want to look at manufacturer patient assistance programs. In that instance, they know it's very expensive. They would not offer $100,000 off a drug if they didn't know that it wasn't so expensive. The problem is only made more difficult as new treatments enter the market at extremely high prices. I mentioned earlier that the average launch price is $300,000 last year, okay? It's increasing every year. And even though a new or existing treatment could be priced at a level, can measure it with its good long-term value, it could create short-term healthcare costs that are so substantial that they would be difficult for our healthcare system to absorb over the short term without displacing other needed services or contributing to rapid growth in insurance costs that could threaten sustainable access for all of us. Go to the next slide. So just to recap, health plans have a willingness to pay. Manufacturers, they have a willingness to discount. Patients have an ability to pay, and pharmacies have an ability to stock and dispense. When I went back and looked at the statute of what does affordable prescription drugs mean, there are two different things in the same paragraph. One is to reduce costs to individuals purchasing prescription drugs through a public payer. And then there's affordable prescription drugs for the state and all of its residents. And then that is to be measured by the annual net spending by public payers to see if the implementation of the recommendations are working. So we can go to the next slide. And here's where I think you all need to make a decision. Now, what does affordable mean? What does it mean in the context of when you're reviewing and assessing prescription drugs, as you're supposed to be doing under the legislation? What does that mean for the residents or people in New Hampshire? And I offer the definition from the National Academy of Medicine that affordability refers to how easy or feasible an individual or more broadly society finds it to pay for a drug. It is a function of drug prices, insurance coverage, family's financial circumstances, and sometimes the purpose of the drug itself. And then when you go into the statute, it specifically asks you to look at those drugs that may cause affordability challenges to enrollees in a public payer health plan. So at different points within the legislation, it asks or tasks you with looking at either the residents or just the enrollees, a public plan, the entire state. And so I will pause there and open it up to discussion. Tom, Dr. Sherman, do you have a question?
Well, I can speak to the intent.
Okay.
And by the way, Gary, are all the senators here, or I've been on the phone listening to you all since you started. Can I be elevated?
You can be elevated to a full member, yes.
Okay.
Actually.
So the intent
Mhm.
was a fairly narrow focus on, that's why public payer is in there. The overall affordability is, we've looked at, during my time in the legislature, we looked at Medicaid expansion and figured out a way to do that without impacting general funds. We reauthorized that. We've also looked at the cost to state employees and all of the public payers in the state, which would include, as Senator Rosenwald mentioned last time or the time before, corrections and other state payments. The goal was to understand costs for the state and make sure that those costs are sustainable. And I think Representative Edwards brought up some of the weight loss drugs that are coming up. I believe it's North Carolina, maybe South Carolina, where they are now regulating who can have those drugs because they're so expensive and having such an impact on the state budget. That was the goal, but as the statute states, not to impact the health of the participant, of the subscriber. So how do we how do we move forward as smartly as possible, controlling as much as we can cost to the state while not impacting the needs of the subscriber. And I'm not saying that's the answer to your question. I'm saying that was the intent, because what was seen, what was happening in New Hampshire, what is still happening in New Hampshire, obviously, what's happening across the country is this skyrocketing prescription drug costs. And it's directly impacting the state budget, and it's going to directly impact it more and more and more. And we need to be as smart as we can to control that aspect of the state budget. I think all of the different presentations we've been hearing show that that's possible. But I agree completely that we need to come up with this definition for the board. But it needs to be a workable definition. I think we need the intent of the bill that put us on the map was really to look at how do these costs impact our state budget, and how can we make sure that we are as smart as possible in being able to control that while not impacting the subscriber.
Thank you, I appreciate that. I still struggle with understanding who the who is, like the state payer. But I'm gonna offer to my colleagues here an opportunity to maybe look at it in a different lens. You see, the National Academies of Science only sometimes considers the purpose of the drug. And maybe alternatively, when we consider affordability, we think of it differently. Instead of affordability to whom, because it seems like the expense is ubiquitous and pervasive across society, even in the subdomains of total drug spend or patient out-of-pocket expenditures. But instead of affordability for whom, I think we should think about affordability for what. And this is emerging more and more, I think, as a pervasive issue in prescription drug usage and prescription, maybe different than when you initially even wrote this. You see more and more specialty drugs, which Mr. Williamson said, alluded to the cost that it's exerting to our system, being indicated for more and more uses. You can see it with the autoimmune drugs. When they first came out, they were called interleukin inhibitors. Now they're broadening, called TNF alpha-1 inhibitors. But my biggest concern now, the GLP-1 agonists that started as anti-diabetic drugs, gets broadened to reduce risk for major cardiovascular events, and now are going to become knocking on our doors, incurring massive expenses nationwide and indeed in the state of New Hampshire for weight loss, which presumably the cost efficacy, the utility of that drug varies considerably across those three domains of indication. Yet we pay the same for that price, for that drug, the same price. And so some other countries, view an indication-specific pricing kind of paradigm. Our country doesn't really consider that. We have some significant legal obstacles that stand in the way, such as the anti-discrimination laws. But nonetheless, I think if we only sometimes consider the purpose or the therapeutic utility of a drug, we'll continue paying higher prices for drugs that have less therapeutic value. And so it's just a lens I think we might want to look at it as. I mean, we look at other states and doing affordability reviews for certain drugs, like Colorado, and they're getting sued right now by one of the major autoimmune drug manufacturers for that. So I think there's a lot of landmines that are possibly along that way. But if we look at maybe the indication-specific cost and utility for drugs, we might be able to make some important changes that could benefit the citizens of the state.
So, Dan, this is why you have your PhD. And I've just stumbled out of a bachelor's program, basically. I think I understood everything you just said. But it seems to me to be, subordinate or kind of tactical questions and issues underneath a more strategic banner. And as I was listening to Dr. Sherman, the thing that really rang true to me is that ultimately, the extent to which this board can help identify trends for the state budget and help us with policies that influence in a positive way the state budget. And of course, it's got to be balanced and optimized with health outcomes and everything. But so I think we still need kind of a strategic layer to this. And I hope that we all value a metric, something that we can measure and really benchmark and compare. So that's my reaction to what you just said.
I've been thinking about the public payers for some time now. It's primarily Medicaid, the state employees and retirees, and corrections. In corrections, the individuals don't pay anything. In Medicaid, they mostly don't pay anything. In the state employees and retirees, it's subject to collective bargaining. And it's capped. And then there's the public colleges and universities, those are public payers, but we really don't budget. We give them some small percent of their budget and they are responsible for the rest. So I don't see that we're really responsible for paying for the prescription drug costs of the public colleges and universities. There's also the judicial branch, which is, again, it's more limited, but I think maybe we need to think about short-term and long-term, because I think you make a great point about these GLP drugs are going to be used for everyone and everything. And not only are they shown to reduce cardiovascular events, but now they maybe are slowing down the progression of Parkinson's and other cognitive declines. And last December, I went to a very interesting presentation. I bet we could get this guide here. He was a doctor who's taken over the weight loss clinic program at Dartmouth Hitchcock. And he mostly worked down at Brigham and Women's, I think, or Mass General, but now he's working at Dartmouth. And his presentation was that basically half the population is going to be on one of these drugs eventually, and it's going to save money in the system because they're not going to have the major cardiovascular event. They're not going to get cancer. They are not going to see Parkinson's progress. But the point he was making was you have to start with the smallest, most highest risk population, and then the money that is saved from bad things not happening to those people is eventually essentially available for other individuals. So I think individuals, I've gotten long-winded today, sorry.
That's useful.
That's
Individuals, I think, benefit indirectly, even if they're not a direct payer. So people on Medicaid benefit if we have a robust Medicaid program, even if they are not paying for the drugs. Same with corrections. To the extent that we're not spending more money on prescription drugs than we need to, maybe we can have more educational or vocational training. So I think there's an indirect individual application, even if the direct payer is the state budget.
Thank you, Dr. Sherman and Dr. Adams.
I just wanted to respond. First of all, I agree completely, and I agree with what you said. I see the what as getting back to what Representative Edwards was hearing from what I said, which is what may be one strategy or a component of how we do our job to make sure there's not unnecessary upward pressure on the budget for covering state or public payer policies. And the reason I keep coming back to that is because we do have a risk of mission creep, of trying to solve the problems of prescription drug pricing for all the residents of New Hampshire. That's not the intent of the bill. And while we may get a lot smarter as a state by looking at all of this, the what and who is benefiting is really important to understand. But getting back to the affordability, if we as a state can't afford to run these programs, that's a real loss for the state and for the residents of the state. And I think that was the original goal. And so getting back to that goal, then what becomes really important as a component of that? And making sure that we are not shortchanging the people we're supposed to be helping by doing everything we can do to, we don't change anything. We just come up with recommendations. That's maybe and maybe those recommendations will change things, or through the legislature, they'll change things. But that's really, I think when you get to affordability, we can start going in the subheadings under affordability, but the bottom line affordability here in my mind is affordability so that the programs that the state is currently running are sustainable within our budget.
I'll defer. I think that you answered my question that way. I mean, I think the board could probably benefit from a very, very clearly delineated set of residents, citizens, I think, people, we're talking about people, right? Who the board has authority over, who the board's authority exists over. So, because I've heard a lot of, the university system and I know we had a report with Medicaid. I'm not quite sure, and that's probably an issue. If board members are not exactly sure, we go back and forth with that uncertainty. Simple, clear, concise language could probably help with that. So I appreciate that. Yeah.
Okay, so I think this may be a new topic, but it's related to the idea of, let's assume for the purposes of what I'm about to say, that we end up circling around and we get comfortable with the idea that a key outcome of this board is to help understand the state budget in context. I think the presumption that's embedded in that is that we probably have this increasing need and demand and opportunity to spend money on prescription drugs while we have the limited ability to invest in them. And so choices are going to need to be made in the future about how to allocate scarce medical resources. And what I think we may need to do is I think we may need to at some point get comfortable with sort of a medical ethicist point of view of how we view this task of allocating scarce resources to potentially unlimited need. And I'm just reminded from the Obamacare years, Ezekiel Emanuel, you all probably know of him, was part of a Lancet paper on the allocation of scarce medical resources. And he came up with this meaningful lives construct. And that paper had 2 or 3 other competing ethical views of allocation of of scarce resources. I just wonder if, once we get our mission statement clear, what our strategic vision is, that we may need to pop back up to sort of an ethical view of what we think we're doing with these scarce resources.
I would just add one phrase to that, because I think that's really important. I would add, when we're talking about scarce resources, how do we be as smart as possible about how we allocate those resources? In other words, we're not just saying, okay, here's the price. And because it costs this, we're limited on what we can give out. What we're learning through the PBMs and the manufacturers and the wholesale market and this complicated system is that there are points all the way through this where we might be able to be smarter as a state, as a consumer of these goods. So not only is it how do we allocate scarce resources, but how do we get smarter about how we use those resources and those strategies that we end up recommending, whether it's to the Department of Corrections or DHHS for Medicaid or in the budget or in the legislature.
So could I get some feedback on that point? Because I think that's a new topic that is being introduced around medical ethics. Does anyone else second that view that we need to maybe have an ethical viewpoint of the allocation of the scarce resources going, 5 years from now?
I agree, I think, ethics is one thing. I think when we pull the utility of a certain drug across multiple indications, it obscures the whole idea of this thoughtful spending that Dr. Sherman was just talking about. So the insurance department is trying to add to its data assets, which we'll be talking about probably today, and I hope weeks and months to come. We're considering getting a subscription to ICER, out of Boston, Massachusetts, that looks at various permutations of cost utility for drugs. And I think that that's emerging, to me, in my lens, more and more interesting. That if we want to be more thoughtful about expenditures for drugs, we have to be directly cognizant of the variations in the utility functions of the cost utility of these drugs for each indication. And ignoring that ignores the main point that Dr. Sherman was talking about, and presumably was embedded in your intent of this legislation those years ago.
Well, I was just I agree with Rep. Edwards on the issue, and I'm just suggesting maybe we want to have a discussion from one of the Dartmouth ethicists. I mean, they have phenomenal medical ethicists there who could come and talk about, one component of the bill, the law, the statute is making sure that patients have access. I can't remember exactly how it's phrased, to the pharmaceutical they need to address their issue. If that's part of the statute, then the ethics of how do we do that if we have limited resources is directly impacted. And I think it'd be great to have an expert who is up to date and read all those, who can help us with the ethics of determining how do we allocate those resources and still make sure the patient is taken care of.
We've had something comparable to this when it was at the medical center, when you have a drug shortage, which we're going through many now. The sad part is that you have enough drugs available to treat everyone. And then somewhere along the way, back to the issue of ethics, how do you prioritize patients? Because you can't treat everyone because there's not a drug available. But you have to have some way to start thinking about what allocates the drug. And that goes back to the thing talking about here, scarce resources. Also, but
So, yeah, not to push back Representative Edwards, because it's thoughtful. I just don't think the word ethics is the right term, because that presupposes that we all have different, sometimes maybe even clandestine goals and targets with what we decide. And I don't believe that's true. I think we all have very altruistic purposes, and we see that for this board. Whereas I think we should look at legislative targets and authoritative targets that consider optimization and value of drug deliveries to our patients, to our citizens. Optimize, that's a term economists use, optimization. How do we get the most value? And the best example are the GLP-1 drugs. Because the cost is massive, independent of the therapeutic benefit. Despite the close substitutes for a lot of the new upcoming indications, we're gonna be bearing that cost real soon. And we probably all think that it's not, you know, the best thing for our citizens, but it doesn't relate to ethics, it relates to obscuring the differences in utility across those conditions of interest.
Sure.
Not all state Medicaid programs cover GLP-1s. New Hampshire does. So, to your point, there might be a lot of people who need it, and you need to understand the impact of that benefit and what we're spending on it. And that could become some sort of, that benefit could be rolled back for the sake of paying for education, or paying for other medical services, right? So we also need to think about what we already provide and how do we maintain protecting the patient, how we maintain that benefit for New Hampshire residents on Medicaid, so they can still obtain access to those drugs. I think we also need to be thoughtful about we need to have a process for examining spending. And just keep it in the back of your mind, because we can't, as a process, just pick and choose drugs. That's not fair to manufacturers, it's not fair to patients, it's not fair to health plans. So we need to have a framework for assessing what is contributing the most to that spending. And to your point about the ethics, maybe it does provide great value, maybe it is really expensive and we just move on. But maybe it doesn't, maybe we're spending too much, or maybe it's just wildly overpriced relative to all the other things we could be paying for to achieve the same outcomes. So just keep in the back of your mind, like, when we want to do these things, we will also need a process by which to get there. And I think procuring the ICER budget framework is a great tool. And for you as a board to be able to assess what drugs should we be looking at or recommending the department to look at, to come back to you and say, this is where it measures compared to existing standards of care or whatever. So I just wanted to pause and say that.
Yeah, a couple of, let me start at the top in the sense of what I think our mission is. I think our mission really relates to who's funding us right now, which is the state. And to some extent, the state's going to evaluate our proposed budget in the future, if I speak my presumptiveness, on the extent to which we have identified things that would allow the states to save money without decreasing access to care. That's kind of where I think we're going, or where we're mandated to go. And that's Medicaid and the state employees. Your point about the university system is a good one, I think. Perhaps a less important correctional expenditures. There are a couple of cautionary tales to this. I'm a big believer, a supporter of cost effectiveness, where you have some kind of measured outcome as your effect. And ethics is getting awfully broad. As a longtime student of end-stage renal disease, one of the early examples was who gets the kidneys. You've got a limited supply of kidneys. And there was a great case study about this mom with 5 kids, but no income, versus somebody that could pay all the prices for the immunosuppression medications. And that's an ethical question for which there is no, at least I didn't have any answer. And my students disagree about what the appropriate was. So if we focus on state budget and the Medicaid outlays, subject to some discussion. I mean, every unaffordable medication is not something that can be made affordable. There are going to be some drugs that are just too expensive for the benefits that they, even if it saves lives. The value of a human life saved, especially I'm getting to it's an old life, probably isn't the value of a neonatal baby. For which the expenditures are huge. So we need to be really careful. Another caution is in the end-stage renal disease. Back in the early seventies, it was really an experiment that to provide dialysis for people whose kidneys had failed. So it was an experiment in national health insurance. And the actuaries spent a good amount of time trying to figure out what the savings would be, and they wheeled kidney failure patients on dialysis, which was then very expensive, into Congress, and said, yeah, this guy would go back to work, and really it would save the system a whole lot of money. Actually, it didn't. It ended up costing a whole lot of money. And when we start talking about the new drugs for weight loss or being applied to weight loss, who is it that's too heavy that can be justified? I mean, I've been trying to lose weight. I mean, Jason, I've been trying to lose it for 20 years, not doing it very well. But I don't think I should, be eligible for, and we need to be careful about this, looking at the mean or median person as presuming that that's the measure of benefit, when indeed it can be justified. The doctor will justify prescribing a medication if acting on what the doctor perceives as the patient's benefit. Back in HICVA, we used to call it Medicare creep. You define DRGs and you think that that's going to be the set of people that are going to get a treatment. But wait a minute, if this is the Oregon example, if Medicaid covered colon cancer where the bowel had not been perforated, but didn't cover colon cancer treatments if the bowel had been perforated, oh, wait a minute, all of a sudden there was a lot less perforation in the diagnosis. That's kind of, one needs to be really careful about that kind of flexibility in the definitions. And we're playing in that kind of world where definitions are really important. Going back, I think we should focus on the state budget as we defined, and talk about the citizen budget, citizen impact as being peripheral benefits. That is, to the extent that which we come out with recommendations for Medicaid, there might be some spillover onto pricing policies outside. So thank you.
So I appreciate all of that. I just want to come back to the medical ethics issues and this one paper, which is about 50% of what I know about medical ethics. In this paper, Ezekiel Emanuel laid out multiple models under which scarce resources could be allocated. And each of those models had a set of principles about how to allocate them among the population. It wasn't an issue that one model had more integrity than the other. It was just that it was a choice between models of which one would be used. And that's kind of my point, is that maybe it would be worthwhile to get an ethical model that's perhaps well defined and well studied and understood as kind of a guiding stone to some of our recommendations about future budgets. I wasn't calling anyone's integrity into question, and maybe I misunderstood what you were
I
saying.
think I misunderstood the theme of that paper.
Yeah, and I can get a copy of it and distribute to
That would be useful.
Yeah.
I'm thinking that the different payers might get different suggestions from us on what they could do. So like in corrections, we might think that extending the 340B program beyond the few kinds of drugs the department's using it for now would save money.
Phil, 340B,
Yeah, oh.
refresh my memory.
It's Gary's can tell you a better description of it, but it's a low cost purchasing program for drugs that is offered for basically low-income communities.
So it's federal.
It's a federal.
Federal program.
Yes, and it's intended to stretch scarce federal resources. There are covered entities like community health centers, fairly qualified health centers, rural health clinics, disproportionate share hospitals, those types of entities, and it's intended for them to obtain an upfront discount. And they make a margin off that spread of the lower acquisition, the high market price charged. They also contract with a number of pharmacies as well to extend that benefit into the communities. But it's not to say that all people should be accessing these 340B drugs. It's just saying that there are low income populations that are best served through these lower price drugs by these entities. And that was the intent of the legislation, to allow for some of those programs to be able to offer, let's say it's a Ryan White clinic. They could offer HCV screening. They can offer a lot of wraparound services with the extra profit. And what we've seen as a model is Department of Corrections, because they provide a benefit to public health when they reduce HCV or HIV transmissions within their walls, and then people leave prisons and enter the community. We can reduce costs that way as well. And a lot of times, because we have a limited budget for corrections to procure drugs, we have to make much more difficult decisions, right, about who in a prison gets what. And often those restrictions are much more onerous than if you were privately insured. So to Cindy Rosenwald's point, the recommendations could look different by program.
Right.
And there are also, so there are discrete recommendations, and then there are also kind of an overarching kind of framework that you could also use over time to assess state spending and to either reduce it or make recommendations. But I think that was at the point, Senator.
I mean, they use it a little bit, but they could use it for more drugs. And for Medicaid, we could look at having a single PBM for all of managed care rather than each MCO doing it themselves. So they're not necessarily who's going to get what drug, but different kinds of approaches to how do we work for more efficiency with the state dollar.
I would say that one of the things that if we're going to look down the road and looking at future support, how do we define success? And right now, we've talked about a lot of what we can do and so forth, but I don't think we have nailed down what is the definition of success. And what I would say is, this is throw it out there. When I think about financial investments, one of the things a lot of people do is benchmark a financial planner, someone helping you. How are they doing against the S&P 500? Are they beating it or are they not? So what I'm trying to think about is that with our strategies collectively, what's the benchmark we want to use to say, that's what is the benchmark? Are we above it, below it, or equal with it? Such as when Mr. Williamson was talking about many things, looking at prescription drug growth. And looking at, say, nationally, at the states, are we finding a way to bend the curve? Are we actually coming out and having a slower increase because of all our strategies? We go back and say, well, it was a 5% increase, but we only had 3.5%. That to me is a benchmark. You can sit there and say, we did something. It's definitive, it's objective. The question at that point in time, is that something to think about here is back to the mission, is how do we define success? I think it's gonna be critical. And what does that mean? Because all these things we talked about are all wonderful strategies, but at the end of the day, it's talking about somebody coming from the military, how do you know you won the war? You got all these battles going on, but at the end of the day, what's the definition of winning the war? How do we define that?
We get the pharmaceutical companies to unconditionally surrender, is that?
I was thinking about that. Could you help us out with that one? Go ahead, yeah. No.
So, I think that's a really great point. how do you measure success? I think the mission that I'm hearing is fairly consistent, which is the PDAB, its role is to create and recommend strategies, whether legislative or in rules or policies, to look at prescription drug costs to the state, while not negatively impacting patients or outcomes. That's a really big goal. But and then under that, we have direct cost reductions. And we've talked about strategies that involve manufacturers, and last time or 2 times ago, Representative Edwards brought up that the redundancy report doesn't talk about pharmacies, and doesn't talk about wholesale distributors, and that may not be their role. So getting all the data together to be able to be as smart as possible and making those recommendations, which would include what other states are doing, but then identifying that benchmark, whether it's the historical benchmark of costs within the state, I think that would be an important benchmark from all of our target populations, which are public payers. But also, what is there an index, as you said? So when I think about what this 15/30 minutes is about, I would propose a mission statement similar to what I just said, which would be consistent with statute. But we've gotten so much smarter than when that statute became law that we have to look at, I agree that we have to look at the ethics of what's happening here. We have to look at outcomes. We have to look at the subgroups of payers in our state system. And it's going to be really complicated. But I think if we go forward with that mission statement, I think we've got guidance on how to do that.
No, I concur. I think in the mission statement, a couple pieces that are critical. One is going to be, what are we talking about? Who's the who? And that's going to be important. We talk about strictly the state employees. Are we talking about correctional? Are we talking about trying to include Medicaid? Are we talking about the university and colleges? Because ultimately they also come from taxpayer benefits, if you will. Municipalities, school districts. I mean, there's so many ways in which taxpayer dollars come into the system, and indirectly they are quote public payer. So I think for the board right now is who is in and who is out, at least at the beginning. We may decide it's better to go with a smaller, like the Department of DHS, Administrative Services, state employees, is put our arms around that one and really focus on it. And at that point in time, can we do anything within that small pilot versus trying to take on so much that we get lost because it's just too much going on. So I think the who is going to be important for us to understand. Then we can talk about.
Well, I would say the who should be driven by what's the biggest chunk of our state budget. So if Medicaid is the biggest chunk of our state budget, which is what I suspect, I think our mission is public payers. How we get there may be to pick whatever the low-hanging, it's not really low-hanging fruit, but the largest fruit, the watermelon in the room, pick that as our first project, and then look at corrections. But if we pick one of them, whichever is the most expensive to the state or the taxpayer, and then we will learn a huge amount about how to approach the others through that effort.
So I think what the saying is put out the hottest fire first. Go.
Right.
Yeah.
I think that's a question of, to your point, it's prioritization, right? Do you want to prioritize Medicaid as your first crack at the apple, or do you want to prioritize state employees while keeping your mission a bit broader?
Yeah.
To say all residents or whatever, to allow you, I don't know, that's just what I've heard between the two.
Although Medicaid is probably the largest, it's definitely the one.
way
The
bigger.
challenge, though, is that it gets more complicated with Medicaid because of the federal issue going on as well, so it may get to the point where it's sort of bogged down because of all the other constraints coming at Medicaid versus going at the state employees, because that's something we truly can focus attention on. It's not small, but it's big, but it doesn't get into some of the potential structural issues that could be in place.
The other criteria to prioritize, wouldn't it be the availability of good data? I mean, I don't know if we have if all data is equivalent.
Well, it's a good point, Representative Edwards. I would say that within the Department of Administrative Services, state employees, most likely they're using a common PBM. So if that's the case, then because we own the data, we're self-funded. I'd go to Commissioner Carlinghouse and saying, there's a way for us to pull data out of the database because it really should be our data. We're self-funded, what they're doing, providing administrative services for us versus if you will getting the financial benefit or financial risk.
Importantly, those data are in the chip.
Right, that's what I was gonna ask.
Did you say that again?
Those data from this state employee program are submitted to the CHIS.
Do we have a way to identify it within CHIS?
There's a pathway we would need Department of Administrative Services to disclose the specific group ID identifiers.
But the rebates, unit level rebates, that's not in. Or is it?
Well, that's in a different reporting responsibility to the insurance department, so Express Scripts does submit their total drug spend and rebate data to the department. And so we need them to specify exactly what plans each set of data, so right now it's aggregated.
Is it drug level? Is it drug specific?
Not yet, and so one of the hopes is with Senate Bill 555 is that we can improve the granularity of the PBM reporting to the department, so we can identify individual group spend, and whether or not it becomes at the NDC level, I guess we'll see.
Senator Romo?
So this state plans just changed January 1st. From Aetna to Anthem. So it's a new PBM, lots of problems.
And there won't be cross data. I mean,
Right.
your benchmark, you were talking about benchmarking, the going forward, comparing growth. But we'd also like to have some kind of historical information. The technical term is difference in difference. We want to see what's happening to New Hampshire compared to what has been happening and what other states are happen in the future. The historic is going to be important. The nice thing about CHIS is that they do have back to the 18 data.
1897, I think.
The 18th
Yeah,
century.
2018, right?
Actually,
So could I just bring us back
Yes.
to our current goal, which is wordsmithing a mission statement? And I would recommend that we let Kirk take the input here and create a draft mission statement for us that we can all look at. And how can we do this under right to know? Can he send it to all of us and then we send back an individual response to him? Is that legal?
Drafts are also not subject to right to know.
Okay, so if he sends that to each of us and we all have an opportunity to wordsmith it, send it back to him. But then this discussion to me has been hugely helpful in coming out of it. The idea of having a presentation from maybe the Dartmouth ethicist after we've done our homework on the article that Representative Edwards has been mentioning. But also, how do we move forward to achieve that mission statement goal? If we're talking about picking a subset of public payers, I would ask us, please don't pick municipalities. That would be a nightmare. But something that's doable, something that can work as a model for future investigation. And maybe you guys could talk about that in the meantime and make a recommendation that we move forward with, whether it's corrections, Medicaid. It sounds like state employees may be the one that makes the most sense. And that we start working on that as a project.
Then that would, going forward, and talking about that project, again, the same thing with the advisory council. Is talk about what some of the strategies that they could discuss at that point in time, because it'd be robust, you've got a lot of wonderful people on that council. And talk about, okay, this is the patient population. This is some of the data we have. What are we doing going forward? But I think critical to that is also gonna be, what's the benchmark? Because if there's no way to show that we have done something objectively, concretely, it's gonna be hard to continue going forward. Whether it's going to go back to the same thing, it could be, we went beyond the benchmark, but we also have data because we supported drugs that had to be utilized for the what, the indication. Because the indication there, so we're trying to get to within the database, we have this discussion in May. Is maybe also looking at. What's the indication for the drug? Is there a way within CHIZ to get the indication that was. Why the drug was prescribed? I mean, those are things I think are important to us, looking at indications as well as looking at the drug itself, but not looking at it in a vacuum.
So just for Representative Edwards, what I recommended is that Kirk take this discussion and wordsmith and then send to each of us the wordsmith version of the mission statement that we could each wordsmith and send back to him, and then we could decide on that.
So we're not talking to each other, we're talking back and forth to him.
Right, and then we can talk to each other in May.
And that keeps us in the compliant with 91A. Cool. By the way, I emailed everyone a link to that article I was referring to.
Can I just?
Yeah, please.
I would like to see us, this to me is the first time I feel like we've actually started taking action in a specific direction to achieve what may or may not be our mission. And so I would like us to really start working on it. If that's, then the next meeting or the June meeting, if there is one, I don't know what your plan is, but
We could tee it up for May 13th. I mean, I don't think we need 2.5 hours to talk about the data per se, but. We can take part of that at that point in time. It's more to test the waters if everything's coming back and we sort of a check-in. About what's going on and how we're doing. Based upon the feedback, it's relatively short. It's only gonna be like, what, 3 weeks? 4 weeks?
What?
May 13th.
Oh, yeah.
So I mean, it's not gonna give us a lot of time.
Yeah.
You gotta compose it,
Mhm.
get it out to us, get feedback to you.
Yeah,
Is that gonna be even doable for May 13th?
yeah, I don't know. I don't. Aren't you going on vacation?
I'll be
next
back.
to-
I'll be back for the 13th, but we don't necessarily have to. I would love to have somebody get in touch with Commissioner Arlinghouse.
Yeah.
And so they could talk to us about. Yeah, so we could figure out what is our next step, which one of the big three are we going to tackle? Do we want to have a presentation on what data is available? Maybe Dr. Aziz.
Yeah, thank you, that's useful. You recall that Joyce Pittman is on the advisory board, so she works directly with those data and
Yeah.
would probably be able to get us access to the group identifiers. And that to me too is the most interesting population because as the chairperson mentioned, a benchmark and the NHID's annual hearing report actually is a very nice benchmark for total drug spend. We saw the trajectory of specialty drug spend as a component of pharmacy has a steep trajectory, steeper than any other domain in healthcare. And that in of itself is a useful benchmark. And so I think picking a population, a sample population, like the state employees aligns most closely with that and most citizens of the state. And that's just the point I wanted to make.
No, it's a good thought. Okay, as is basically by looking at the collectiveness, it comes out of the report, if I understand it correctly, from the Department of Department of Insurance Department. In there, you have, per member of month, whatever you have, that could be, in a sense, the benchmark, because that's really here, so it's our own residents,
That's right.
right, our own prescribers and so forth, et cetera. So if we could then use that maybe as the benchmark in saying within the subset that we're talking about, how did it perform against the overall group? There's some value to that.
And what are its policies that are in place?
Yeah.
So how could those policies or strategies
Right.
be reconfigured to lower the curve, blunt curve?
Would that include the retirees or just the active employees?
I don't know, we need to get, the group identifiers for the specific subunits of the state employees plan to identify that. That's why I think we'll be blessed to have Ms. Pittman on the advisory board in the support of Commissioner Arlinghouse to get that. I think we aim to do important work that can help the state employees health plan, but there are some gaps in the information and Mr. Williamson's already identified some of those and hopefully can be very useful in advancing that initiative to get better data and make that population of interest much more representative of what goes on in the entire state.
Because it's not huge. It's like 25,000.
Yeah, I'm
I
sure.
mean,
they're
and the
identifiable.
retirees.
Would be interesting when you go back to the insurance department in the database, because my concern is that if the sample size we have is so specific to the overall size, then we need to find a way to break it apart. And if the sample size that we're talking about is like 5% of the overall population, I don't think it's gonna skew things one way or the other, but if the sample size is 80% of the population, then I would be concerned that we're benchmarking against ourselves. So if you can find out within the database, within the insurance department database, the state employees, that particular population, what percentage is that population compared to the overall total? Yep. Just to
We know
avoid
it's less than
ourselves.
30% because less than 26%. Ms. Morgan?
28% of the CHIZ is self-funded.
So 28% of the CHIZ is the ASO, which is the proxy for self-funded, which means in there are the state employees, but there are other self-funded plans in there. So it's probably somewhere around 20% of the CHIZ is the state employees.
Can we break it apart?
The hope is to get those identifiers so we can identify which of the self-funded
Yeah.
plans representative of the CHIZ. Need those.
I need to get simple and mechanical again. We were on this presentation on defining affordability, and it has some nice concepts. It's got like slide 5,
Yeah.
where it says affordable to whom. We had a nice 30-minute discussion of what we think affordable to whom may mean, and we're talking about a specific subset of the state budget, I believe. And so I'd kind of like to see an updated version, maybe an ongoing version of this, to help document some of these major decision points that we're making.
Yeah.
Because this is theoretical, it's nice, but I think we've gone beyond this in sort of an applied way.
Good. So,
And that's what Mr. Williamson's gonna work on, is the mission statement, which will be circulated, which will include the who, the what, a little bit. And at that point in time, if we can work with Dr. Aziz about benchmarking, if we can use the insurance database itself to benchmark against, pull out the sample from the overall population, so we can benchmark the subset against that other remaining part of the population and see how we're doing. You know, we going up, down, what's happening, because at least at that point in time, it stays within the confines of New Hampshire versus someplace, say in Montana or California, which may have whole different markets going on, which brings it closer to home along the way. Doctor.
I think it'd be nice to have a state benchmark and a national, not federal, but a national benchmark if there is one that could be identified, just.
Or maybe a subset of states that we externally benchmark,
That's
right, something like that.
That work, something that we can look towards, and then the question at that point in time is not to get into granularity of it, but when I talked about this before with some folks down at Portal, is be careful about the composition of your population, because you have populations that are elderly that you benchmark against versus young, healthy population. So we have to be careful when we choose a benchmark that it is representative of our own patient population demographically.
Right, council, to not just have state aggregates, but to have drug class division. It may be that we're very successful with, you know, a do minimum lab or how, you know,
Yeah.
it's not the,
Mary.
and not elsewhere. And which brings up, what we're looking at is a before and after, so some kind of policy. Just the board's existence, I presume, will not have an effect. So we're talking about making recommendations and seeing whether those have any impact. That's going to take more than 2 years to implement.
It's gonna take a while. One of the things I'd say is that as an economist, we have to, is maybe thinking about what would be an appropriate benchmark.
Yeah.
If you don't mind getting together with Dr. Ezra, Dr. Woodward,
And you.
and talk about that, because
But
it's
Yeah.
one more regional, if you will, or something national, and then one within our state. I think that would be helpful to identify some sort of a benchmark to be utilized.
Yeah.
So the other component of all of this, I don't know that we've talked about much, is the timing. And if we're intending to influence the state budget, the House gets the governor's budget like mid-February. Does anyone, can anyone even conceive that we might have some expectations or recommendations in time for mid-February to be included in the budget?
No,
Is that just too much, right?
We might have some, well, we could have some legislative recommendations,
recommendations.
but specific budget recommendations.
Yeah, I mean, because if that's our goal is to influence the spend, then the way to influence it is in the budget cycle, right?
Well, it gives us an aggressive goal.
Yeah,
Here's
sure.
the timeline.
One of the
Yeah.
things that not to,
And if it's not that, then it would be 2 years later, which is a more attainable, but do people have the patience to wait 2.5 years to have a reasonable?
or the legislative will.
I just-
to do it quicker.
We may find true low hanging fruit
Yeah.
in the system if we can look at it over the summer and
And one of the things I'll, again, back to House Bill 1365, and I'd like to see it more so, is that when you look at drug spend, because it came out in the Insurance Department report, biologics account for a relatively small percentage of utilization, but a significant amount of dollars. In that arena, if we found a way to bring more market competition between the biologics, which is that's happening in other countries, like in Europe and also in Japan, and let the market forces do exactly what they're supposed to do, is bring competition to the market to bring prices down.
So something that narrow would make actually a decent HB2 item, I think.
And that's aligned with what my understanding of the board's mission, way back when I first started, was promoting transparency. And more of a passive, but non-trivial, very powerful approach that balances the important needs of, innovation and drug delivery for the patients to get important drugs, but government oversight when necessary. So transparency is really one of the things that may not necessarily require anything costly, rather identifying legislative targets. And I mean, the insurance department lauds your House Bill 1365 and aims to testify in support of it, because that's a great example of passive, but powerful transparency approach to letting the market function more optimal. And I think that's how I vision a lot of the next 12 to 18 months. The frontier of the work from this board, it's transparency.
It's, in fact, the competition, because you have the medical side and you have the pharmacy side. In the medical side, we've done a lot with trying to bring down pricing overall with some of the biologics, because at that point in time, just the way the payment model was set up. On this side, it's just evolving, it literally starting, and what caught my attention was back to the Mayo presentation. And they talked about what I call payment reform, I'm not saying we're there yet, but if you have 9 Humira products in the market, why are you paying the highest price all the time? Why aren't you setting a payment and saying, if this is what it is, we'll pay $1,000, what I'm just using numbers. Humira wants to charge $80,000, I think it's $100,000 per year when you pull the numbers the other way. It's $100,000 a year. There's another one just came on the market, it's probably only $15,000 a year. Why are we subsidizing $100,000 one when we have one available for $15,000?
This reminds me of what Anthem did with colonoscopies 10 years ago, when they were building their network, and they found that the range in New Hampshire was about $1,500 to $8,000 for the same procedure, same
Right,
same CPT code, I mean, same everything. And what they said was, they said, this is acceptable, and we're gonna build our network off of, I think Nick Bayless was driving the data on that. And so similar, what you're talking about is, I mean, we have to, we're only making recommendations, but it might be that the public payers want to be thinking about similar approach with drug costs.
so I think this is gonna help you. I look forward to your mission statement, weaving this all together. I commend you for trying.
I'll keep it short, I'll keep it short.
Down to a page, and then at that point in time, you send it out to all of us, we'll send back feedback to you on May 13th, you can try to. Tweak a little bit at that point in time, and then hopefully by June, finalize it.
Sure.
Is that kind of sequence? All right,
Let's see one more thing.
you did.
I won't-
You did.
That I think that we ought to be anticipating for our catcher's mitts for some of these recommendations. Who are the catcher's mitts? So one catcher's mitt, I think, it can be HB2, because that's all about the budget, and to the extent that we have something very specific that's budget oriented, I think HB2 is appropriate. If it's a kind of a bigger thing, then policy needs to do a whole bill, so that would be another catcher's mitt, is that different things would be good to go to a policy committee. HB2 could catch a lot, and then who the other catcher's mitts are, I don't know, but those are the legislative two that I think of, and how we maybe should be thinking about how we pitch a recommendation to who.
Well, one of the other catchers mitts may be the people who are running the actual plan that we're looking at. So if they can do it without a legislative change through rulemaking or policy, that would be the simplest and quickest intervention.
I think it.
And that's why it's great, by the way, that she's on the board,
Right.
on the advisory board, because that can't get more direct than
Well,
that.
One of the things we talked about, not to go down rabbit hole here, careful. In the goal for this year was the concept of what I call aggregation of not the PBMs themselves aggregating, but as buyers, multiple buyers within the state, typically within the employer, universities, municipalities. Is it feasible for us to look at a common PBM we all as buyers utilize? Let's bring the market forces, and bringing all the buyers together. At that point in time, work toward the common goal of having a common PBM. Not saying it's the answer, but that's one of the things we talk about. To me, that'd be a great opportunity for the advisory council to talk about that kind of a strategy. What's involved? Would it work? Can you get buy-in? Those are things we talked about before.
I filed that bill, I think, in 2007.
2007, huh? We're finally getting there.
Didn't go anywhere.
But those are things, again, not to try to solve it today, but that's again back to a strategy where it's allowing for the other self-funded
Right.
plans, if you will, to come together and talk about a strategy. Can we all work together as buyers to buy something? That's kind of a co-op. That's kind of the concept behind it.
Sounds like a rabbit hole to me. I'm just kidding.
Yeah, it did. Looking for Harry Potter. So that's pretty much affordability. The other one talking about in the mission of the board, the redundancy report, we did get some feedback. I sent it out to everyone. It's on the board website. I think one of the things that we saw from the comments I read through, and I wanted to talk this over with Dr. Azaz. What are your thoughts on looking at the feedback and the insurance department redundancy report? How do you think we can take this information back from the public and sort of utilize it towards our goal with the redundancy report?
Yeah, I mean, some of it was surprising, some of it was plausible. I think the commissioner was here, it was last month, communicating an openness and willingness to work with the board and expand actually the insurance department's data collecting authority and assets to better inform the board, acknowledging either overtly or otherwise, acknowledging that there may be other data requirements that go beyond the ability of the insurance department to either currently or prospectively gain new data. You know, it was my understanding that subsequent to the board receiving the report, that all board members were planning to give their individual feedback and maybe collective feedback and presumably public feedback to holistically come up with a good set of legislative targets to strengthen the board's authority and ability to achieve its goal and mission. I'm delighted to hear this new advent about creating a mission. I mean, I think that's key, delineating the population of interest. So I think there were some things that I got my highlighter out and highlighted in green the things that I agreed with, and in yellow the things that may not necessarily been aligned with our interpretation of the statute and those types of things. Some of the commentary in here relates or related to parts of 126BB that are already repealed. And so I think those were advents that were born out of legislators, policymakers efforts, not anything the insurance department said we need to do this. And so what I think is clear, and it's our perspective, and it's the commissioner's directive to me, is to ensure that not only do we share data that we have within the confidentiality provision, but we also strive to get improvements in the sensitivity and specificity of our claims data and our other reporting data born from other reporting requirements for GBMs and insurers with regards to prescription drugs, namely the rebates and what happens to it, where does it go, what group does it get disseminated to, a more actuarial approach, if you will, a more granular approach, so that we can better serve the board in you know, its mission. And that's one of the things that we're doing now. We're currently in the rulemaking process, revising our rule INS 4000 in this case, which delineates under the authority of 420G11 the payer's requirement to submit claims data to the insurance department. So we've identified, and Mr. Williamson's helped with a few domains, and I think there's a plethora of others he can be helpful with. And I aim to do that in May, the meeting in May, to identify specific data reporting parameters to expand and improve the sensitivity and the specificity of our data for that purpose. And so I'm very confident in doing so, in broadening that current process and deepening it, that we really can support the board's endeavors. I read in here something that I feel is demonstrably false, is that there's an unwillingness on the part of the insurance department to share. That's not true, really. There's a certain, you know, as legislators, you're aware of competing interests, and there's this importance, and we see this daily now in our society. The protection and confidentiality of data. It's really important to our society, and more so, and Representative Edwards, you have a deep history of this. It's important to the healthcare system because there's lots of sensitive and commercially valuable information there. So the confidentiality provisions that are part of the insurance department's authority to collect the data, they're key. they were key to open the door. New Hampshire was the first state in the nation to collect claims data. One of the key factors associated with that was the assurance that we would protect the confidentiality of this important data, and that provision still exists. We take that seriously. By no means shall that be interpreted that we don't want to optimize the value or share that with the board. We want to do that, but within our statutory authority.
So, I spent a whole bunch of hours with your redundancy report, and I don't see it as at all. What's the word? Not protective, but not willing to work. I look back at the original bill that created the redundancy report. And it said that the report was to be generated by the Department of Insurance in collaboration with PDAP. And so I've come up with 3-4 pages handwritten of things I'd like to sit down and discuss with you about specific parts of this. But one thing that is, and may go back to the letter, the comment that was in the letter. We have, it's currently suspended, but in Article 9 or Part 9 of the statute, we have an ability to get the data we need to do the job we need to do. But the very beginning of that, in section, I think it's B, says, first, you need to see if those data actually already exist. And only if they don't exist or are unavailable, do you go on to do some data gathering of your own. I think it makes a lot more sense for us to work with the department or departments, whether it's corrections or Commissioner Arlinghouse or DHHS. So it's not just DOI to look at data, but we may need to get granular, invoking our own confidentiality requirements at a level that you have the data, but that we don't have access to it because of that firewall that you have around the department. That might be an opportunity for a memorandum of understanding or opening section 9 so that we can actually get the granular data directly from the pharmaceuticals or PBMs. But in any event, what I'd like to do, because I don't want to take up the board's time, I'd love to sit down with you before the 13th if possible and walk through the feedback I have, some of which is a little bit similar to the other groups, but it's sort of, it's pretty granular. And then you can either like incorporate it or.
It's a good observation. Going through it, what I saw was is more than two, but two that caught my attention. One was the issue of data overlap and redundancy. I think it's important that somehow we identify not just what the insurance department needs, but this board needs, the Department of Health Services. People are going to use that data, the data sets for different reasons. So I think we should be thinking about what different entities would like to have in a database somewhere. And then at that point in time, who's going to collect it and who has access to it? What's that process?
Right.
That's on the data side. The other one I look at is the mission. That's why I would be so critical to what our mission is. The mission of the insurance department versus the mission of the sport. I see them as being synergistic. We're both trying to, at that point in time, make drug therapy more affordable. But what does that mean? It's sort of a subset of insurance. It's not looking at the auto insurance and homeowners insurance. You look at the whole market, we're looking at a very small piece of it. It's an important one, dollar-wise, as well as patients themselves. That's why I took away from the redundancy report. Is there ways for us to work together collectively in a collaborative manner across multiple entities on the data sets? And then at the same time is how do we synergistically work with the insurance department or even Department of Health and Human Services in trying to achieve our own mission? That's kind of what I took away from it all. And thank you for taking the time to write whatever you wrote, because sitting down with Dr. Ashley, because that's important.
Home.
Yeah.
Can I make a comment?
Yeah, please.
So in response to Dr. Sherman's comment, that's exactly the type of feedback that I envisioned, and I think is optimally constructive in informing this draft report to take on its final form that will be delivered later this summer or early fall. So identifying the state employees insurance plan, we have a person on the advisory board that could maybe help make that process easier, and using that as a direct source of data. And, you know, that's an example of a data asset that, even though we have that in the CHIS, so redundancy isn't this categorical term, redundant yes or redundant no. There are different levels. It's really a continuous term in my mind. And so whereas we have that data in the CHIS, we also have a state agency that has direct access to compartmentalized components of that data, and we could get that easily and seamlessly with all of the data confidentiality provisions and requirements that exist with the claims data. But that's an excellent example of a constructive approach to the board providing feedback for the report. And I'd like to see more of that.
Dr. Ozell?
I just want to clarify, when we're talking about confidentiality, we're not talking about individuals. Because that data is not in CHIS. There are no individual identity. So the data that you're concerned about protecting is corporate.
Yeah, I would say, yeah, I call that institutional
Okay,
confidentiality. So
But
So-
not people, it's not individual patients.
not per se. There's this idea of what people call constitutional disclosure risk, where if you get certain parameters of interest, that people can start making, you know, deductions and inferring who might be in there. But with such a large population, i.e. the state employees, that may be challenging, but it's noteworthy that at least from a legislative standpoint, that's, you know, there's a lot of resource that goes into even protecting against this constitutional disclosure. So that you can constitute by taking a few things.
So I don't know that term constitutional in that sense. What I do know is that we have an obligation, I think, beyond that certainly includes, but it goes beyond the protection of personal data.
Which is
I-
not in there.
Well, I know, I'm hearing you and I'm accepting, I'm agreeing to agree with what you just said. But I would just extend that to say, I think we do have a duty to protect business sensitive data. There's potential, a great deal of business sensitive data that we could have access to that we should not be disclosing publicly. Right, so it isn't that we're just worried about personal data, we're also worried about the confidentiality of business sensitive data, I hope.
I think.
And can I just
Yes,
ask you a follow-up?
Yes,
So are the rebates, the final rebates in CHIS?
Not in CHIS, it's a different reporting requirement to the insurance department and pursuant to New Hampshire RSA 402N6, where licensed PBMs in the state, so the insurance department license and renews licensures for PBMs. As part of the annual renewal, they're required to submit a rebate summary that includes total drug spend and aggregated rebates on an annual basis, and it's attributable to specific plans.
But it's not by specific drug.
No, and now we're working on, there's a new advent. Morgan, can you help me on the nomenclature for the new prescription drug, non-claims data reporting for prescription drugs, taking on the
Senator.
CDL, the common data layout, Morgan?
Absolutely. Last week, I believe it was, the APCD Council over at UNH implemented a non-claims-based CDL, common data layout. So they have one currently for APCDs where it's, I think, like 140 plus standardized variables for APCDs that states that have current APCDs can implement, or new states can just go with that model if they're coming on with an off-claims database. Last week, they implemented what they call a non-claims payment CDL, I believe. And that has a whole section on pharmacy rebates, and it is aggregated at the drug level, I believe. It also gives us data on capitation. And there's two other sections, I believe, I should have brought it with me. Two other sections that really broadens the whole claim database. That we have, I think that we would have access to. It's something that I want to put into our INS 4000 rule changes. But that's probably not gonna be for. A year and a half would be very, great. 2 years probably would be more likely to have that implemented.
And that's part of improving the claims data, which is getting broader and broader, that I'd like to include the board in, and Mr. Williamson specifically in that process. So, so the board can reflect its interests in what we're doing currently, and that's an ongoing process.
Yeah, my understanding of CHIS, is that there are not individual identifiers in the sense that an individual can be identified. But if somebody has a prescription of one drug, and then a month later gets a prescription of a second drug, that CHIS allows you to identify that individual's history over time. Would that be fair?
Yeah, I mean,
So
they're not, it's not a person, it's a de-identified member key, but yes.
it's a key, but that key represents that person through time.
But it has no identity.
Right. You don't have the age, you don't have the
Mhm.
zip code, you don't have the name, you don't have, well, anything that can be, that's your constitutional identifier.
Yeah, but
You could
I'll argue-
make a good guess.
I'll argue not to argue, but to say that zip code, sex, age are in there. So that's,
Some big zip codes.
Right, but if it's less than 20,000 people, you
Yeah,
can't
yeah.
report it.
The concept is you're not supposed to be able to, somebody like me can't take that information and go backwards.
Yeah.
And the same thing I think is true in the corporations. What my worry is that in the interest of confidentiality, stuff that we need, we won't be allowed outside of the insurance department. That's,
And that's-
If that's the case, I think we could need a fix. I think it's implied in our statute, the PDAB statute, that we have high-level confidentiality requirements as board members. And if that isn't sufficient to convince the insurance company that they can disclose to us in a safe way, we need to make that more clear. But I think the intent was we're trusted individuals that can handle business sensitive and personal data if we come across it.
And that goes back to, I think, what I'm concerned about is that as we look at data assets or data sets, if they're here, but they can't be shared over here, then over here has to have its own data asset separate from this one. And that's where the redundancy comes into it, because legislatively, we don't have the ability for organization A to use the data in organization B. Dr. Sherman?
I would guess that there's probably a way to work this out, but remind you that right now that our capacity to look
Right.
at data at that level is actually suspended.
Correct.
Until 2025.
Right.
That's section 9.
Section 9.
So
I'd have to relook that. I don't think we suspended the confidentiality trust of the board,
no, it's
unless that was accidental by handling the whole paragraph.
section 9 is suspended for the biennium ending June 30th, 2025. And I believe that's where we have the capacity to look at data at a very granular level. I'd have to look back through, find the confidentiality. I don't think the confidentiality is suspended, which is, our requirements.
Right.
We're criminally liable
Right.
if we breach confidentiality in pharmaceutical information. I think that's actually tighter than the department.
So the criminal penalty, that was not suspended.
That was not
That
suspended.
was not suspended, but the entire section on examining the data and all of that, that was suspended.
So the intent, as I recall it, was to suspend the authority of the board to send data queries under penalty of non-compliance. That was the intent. If it was overbroad, then
It was.
sometimes some of those people aren't very good at their jobs.
I'd have to go back and look at the confidentiality section, but I think the confidentiality provision was left intact.
It was.
If we see the data, yes, we are bound to the confidentiality. The question is, can we see the data?
But, and that,
That's goes
and the
back.
data actually exists. I had I really don't want to take the board's time, but I had a lot of questions about. There was one thing in the redundancy report where they get incredibly detailed PBM data. But that expires this June, their access to it.
Yes.
And I don't know, that might be something that we want to look at, whether that requires legislation or.
There is a Senate Bill 555, which has crossed over to the House, is currently being heard, and we were reached out to provide some insights into, how to improve, with specific regard, how to improve the insurance department's ability to collect that data and give reports to the legislature on total drug spend and rebates. And so that's currently being heard. That's the first domain. The second domain is to be able to better give the insurance department better authority and ability and insight to track the value of what's being done with the value of the prescription drug rebates. So how insurers are applying rebates to either offset future year premiums, premium increases, and or give point of sale rebates. Yeah, and so that's the current context of that bill that's being heard by the House, I think, next week.
Thanks for your comments.
Are we still on reaction to the public feedback?
Well, we do need to get the public and ability to speak.
So the redundancy report, so yes, we're moving on to, let's be all set with far as this. Sounds like,
I just want to make one note about data and data confidentiality. It's important for the board to know that there are two federal Supreme Court cases, one in Arkansas, I think one in Oklahoma, Already, and not sure of the Arkansas, Rutledge, which is the PCMA cases that relate closely to state oversight over ERISA plans and PBMs in general. And so we just want to be very cautious with what the ongoing, I'm not sure what the right word is, litigation climate is in that area, so that we don't try to stretch too far. We have a lot of good data assets. We want to strengthen those that we're able to here in the state. And we acknowledge clearly, and this is an iteration, but acknowledge clearly that we will need to reach outside for sure of the insurance department to even get better data, acknowledging and recognizing that there is a finite limit that really, if you look at federally, that lens is clear what that limit exists like today, unless we want to run the risk of litigation.
so right now, as a follow-up, May 13th, we'll have a meeting on the data and try to understand what data do we need to achieve our mission. I believe by that point in time, Mr. Williamson will distill our feedback, if you will, and come back with something to the board as a quick discussion, then get his board to check in, and then hopefully the June meeting, we can finalize what it is.
Sure.
Okay. And then as far as the redundancy report, Dr. Woodward, Dr. Ezra, you're gonna talk about preparation for, again, it's not so much redundancy report, but be sure that the preparation for May 13th, we're on the same page, we're looking for data elements. Okay.
Yeah, I'd like to address one thing that I picked up in the public comments. It struck me as I was reading that from sort of a policy perspective, that there was some concern expressed relative to the idea that elimination of redundancy is by its nature an attack on the effectiveness of the board. And I just would like anyone who was concerned about that to know that, in my view, eliminating redundancy improves efficiency and effectiveness. The goal is to improve effectiveness at better utilization of resources. It's not to dismantle anything. It's not to disable anything. So I picked that up in the fact that there was a concern that trying to identify and eliminate redundancies was some way going to jeopardize the capability of the board. And I don't think that's the goal.
That's important. Getting down to the time to wrap up public comments. Anybody? Can't see behind me. No. No. Okay. Good, quiet, crickets. Anyone on the Zoom?
My mom's stuff. Here's some.
If there's anyone on the Zoom virtually, if you'd like to make a public comment, please raise your hand. No?
Sometimes I don't know how to raise my hand when I'm a Zoom participant.
Okay.
Can you tell them how to do it? It's could be intentional.
Well, hearing no public comments, Dr. Sherman?
Can I just tell people who wrote these letters,
Oh, definitely.
NHPERG and AARP, thank you for, I mean,
Yes, absolutely.
from me, hopefully from the board,
From the
thank you
board
for the
as well.
feedback, it's
I
helpful.
was encouraged about two things. One is that people are paying attention to the board and our discussions here, so they may not be in the auditorium with us. They are definitely following what we're doing remotely, which is encouraging. And I do agree with what you're saying, Dr. Sherman, that recognizing their input, what they've done is very helpful. And I think also as we move forward with the insurance department, that when we think about collaboration, it's not just collaborating with the board, but collaborating with other stakeholders and saying, okay, what can we do collectively? So it's not just the insurance department and this board. I think we need to think about it more holistically and open it up for public comment.
Yeah, and I'd like to iterate that the insurance department is grateful for the public comments and ask the board collectively or the chair, what your vision is to work with the authors of those reports to help inform the redundancy elimination report, the final draft. We're open and receptive to that and truly do want to improve the efficiencies and economies. I see redundancy that same way, Representative Edwards, is that, it's not a bad thing. It's making us more efficient. We reached out to, Representative Merchant to help advise us on the prescription drug high cost reporting issue that we're having because there's subject matter experts, and that's a proxy for the authority of the board to have an impact on the oversight and regulation of prescription drug markets. And more of that is really in our lens for the future. And we're open and receptive to that. So I want that to be clear to everybody on the board and to the public that that's the insurance department's perspective on this.
Thank you for that. Any more comments before we adjourn? I'll make an undisputable motion to adjourn at 11:35. Thank you all.
Thank you.
We're already checked out.
Yeah.